Okay, good evening, everybody. So I'm Tayla. So our talk, like Tammy said, is on EFAST, which stands for Extended Focused Assessment by Sonography in Trauma. So just a quick overview. So we're just going to chat about the introduction of EFAST and some of the literature behind, where it originated from and why it's such an important tool in our EDs. Then we're just going to chat about the advantages and disadvantages and compare it to other methods of imaging, the indications and contraindications for the procedure, and then probe placement and positioning. So the basics of EFAST. So the main point of EFAST is that it's used to identify free fluid in the peritoneal cavity. So the sensitivity is approaching 96% in detecting as little as 800 mils of free fluid. Experienced practitioners can detect as little as 100 mils of free fluid. It involves detecting and directing the ultrasound probe in 5 main regions, which we'll get to just now. EFAST is only formal if it's performed by a certified practitioner. So a very important thing that we need to use in our documentation is to actually document and write that it's not a formal ultrasound and that we are unaccredited practitioners when we do the ultrasound, just to medico-legally protect ourselves. So a positive EFAST can rule in free fluid. It indicates additional management and investigations should be used if there is free fluid detected. And it's important to reevaluate the patient's condition in a positive EFAST. For a negative EFAST, it actually means nothing. So it's important to repeat EFASTs that are negative and to do serial ones. And once again, also reevaluate the patient's condition. So whether an EFAST is positive and negative, it should never be used in isolation, and the patient's clinical picture should be taken into account. The different views of EFAST, so there's 5 basic views. So the first one is the right flank view, or the right upper quadrant view, which is depicted by the black A in the photo. The pericardial subcostal or subxiphoid view, which is D in the photograph. The left flank view or left upper quadrant view, which is probe B, the black B in the photo. And the pelvic view, which is view C. And then the 2 extra ones, which makes it the extended FAST, is the anterior pleural views, which is probes A and B, which look at your pleura. So once again, just to go over the probe positionings. So the right upper quadrant, you're going to be looking at your liver and your kidney and your diaphragm. So the main point there is to look at Morrison's pouch. And then your subxiphoid view is to determine whether there's free fluid in the pericardial space and to assess filling and contractility of the heart. The left upper quadrant view shows us the diaphragm, the spleen, and the kidney, and you're looking for free fluid between the spleen and the kidney. Then the suprapubic view is to detect free fluid in the bladder and also in the pouch of Douglas in women, so between the bladder and the uterus. And then the view not depicted on here is your chest view, just to look for pleural lung slide. Okay, so the advantages and disadvantages of EFAST. So the main advantage is that it's quick, it's portable, and it's non-invasive. Less expensive than CT scan, and there's no ionizing radiation. So it's great, especially in our pregnant patients. It's sensitive and specific, as I mentioned earlier. It's repeatable, so you don't have to physically move your patient. The patient can stay in the ED and we can repeat it as often as needed. And what's great is that it's also therapeutic, so emergency interventions can be performed. For example, if there's decreased lung sliding and there's a lung point, you can insert an intercostal drain if you detect a pneumo. Disadvantages is that it's a low sensitivity and specificity for detecting hemoperitoneum and visceral injuries. So it can just say that there's free fluid in the abdomen, and it can't necessarily tell you what that free fluid is. It's operator dependent. So junior staff that haven't used the ultrasound probe too much, may not pick up free fluid as well as your more senior staff. and it does not adequately evaluate retroperitoneal bleeds, gas-containing structures, and the mediastinum. Just another point here quickly, that in terms of it having no ionizing radiation, yeah, so I did mention that it's great to use in pregnancy. So this is just comparing the different diagnostic modalities that we do have. So there's EFAST, there's a very old-fashioned diagnostic peritoneal lavage, which I don't honestly think is actually ever done anymore, and then the CT scan. So the advantages of the EFAST are what we've just gone through. So it's a bedside exam, it's non-invasive, you can do serial repeat exams with the high sensitivity and specificity. The disadvantages is that it's operator dependent, it can't identify specific injuries, and it's poor for hollow retroperitoneal organ injuries. One of the big disadvantages as well is that it's quite difficult to do in obesity, and when there's subcutaneous air or a lot of bowel gas, it might be quite tricky. Diagnostic peritoneal lavage, so the advantages is that it's sensitive for identifying intraperitoneal blood, because obviously you get an aspirate back and you can confirm that the fluid is specifically blood. It can be done at the bedside. It can be done in 10 to 15 minutes. And the massive disadvantages is that it's overly sensitive and there's an increased laparotomy rate. It's difficult in pregnancy and it cannot be repeated. And obviously it's quite an invasive procedure. CT scan, the advantages of this is that it identifies specific injuries. It's good for hollow viscous and retroperitoneal injuries, and it's got a very high sensitivity and specificity. The disadvantages is that it's expensive. In an ideal world, it takes 30 to 60 minutes to complete the study, but we all know that in our setting, it takes much longer to actually get a patient to CT scan. Ideally, it's also only for stable patients, so your unstable trauma patient would benefit much more from an EFAST than a CT scan. And it's not ideal in pregnant patients because of the radiation. However, it shouldn't be omitted because of pregnancy. So what's important to take home from this, especially in our setting at Rahima, is just because a patient is pregnant doesn't mean that they shouldn't get a CT scan. So just a little bit about the sensitivity and specificity. So in terms of emergency department ultrasound being used in the evaluation of blunt abdominal trauma, so they did a study back in the 1990s. It was in 1994, and it was a prospective study that a surgeon performed using ultrasound as the primary adjuvant modality of injured patients. So basically, the outcomes used were the ultrasound detection of a hemoperitoneum or pericardial effusion. And the results showed that there was a sensitivity of 81.8% and a specificity of 93% for detecting the free fluid. And it was very good and useful in blunt trauma patients specifically. So this is just a little snippet from the actual article. So just once again reiterating that the sensitivity and specificity and accuracy of bedside sonography in identifying intraperitoneal hemorrhage was 81% and 93.9% respectively. So basically the ultrasound study provided an answer in less than 1 minute in most patients. The basic EFAST principles, so like I said earlier, it detects free intraperitoneal fluid, so not necessarily blood. So fluid could be blood, ascites, urine, or intestinal contents. Blood and fluid pools in dependent areas, so the pelvis is most dependent, but usually where we go first when we're looking for free fluid in the abdomen is the hepatorenal fossa, which is Morrison's pouch. So that's the most dependent area in the supramesocolic region. It's important to interrogate the entire abdomen properly, so not just using one static view. So it's important to actually move the probe around and see the entire area and visualize the tips of the organs, which I'll explain in the videos in a few slides' time. If you're unable to visualize a whole view, then it's important to document that it was an indeterminate scan. So in terms of liver and spleen injuries, these represent 2/3 of cases of blunt abdominal trauma, and it's very important to visualize the tip of the liver and spleen on your views. So in terms of where to begin, so you must always protect yourself, so use gloves. You need an ultrasound machine. The best probe to use for EFAST is the curvilinear probe. You must always explain the procedure to the patient if they're awake and they're able to understand exactly what you're doing, and to try and get verbal consent. And then you position the patient lying flat on their back, and you can even position their arms behind their head to improve the sensitivity of the exam. So you can adjust the patient into the Trendelenburg position in order to actually obtain the views. And then the other thing that's quite important is also to explain the results to the patient. So often we just kind of do the ultrasound and we kind of move on and we document our findings, but it's important to tell the patient what you are looking for and then what you find, because patients are often very stressed and worried in these settings. So the first view that we'll discuss is the right upper quadrant view. So in this view, you're going to place the transducer on the patient's right flank in the mid-axillary line in the 10th to 12th rib space. The transducer indicator should be aimed towards the patient's head in the coronal plane, and the aim of this is to identify the liver, the kidney, and the diaphragm. You're going to sweep the transducer anterior to posterior to visualize all the potential spaces, and you're going to look for free fluid above the diaphragm, in Morrison's pouch, between the liver and the kidney, and in the pericolic gutter at the inferior pole of the kidney. Okay, so we're going to orientate the probe. So you will have placed the probe in the mid-axillary line between the 9th and the 11th or 12th intercostal space, and you're going to rotate the probe anti-clockwise into the intercostal space to obtain an unobstructed view. You're going to slide the probe towards the patient's head along the lateral test wall, and you're going to look at the interface between the liver and the spleen. So this view shows nicely the Morrison's pouch between the liver and the kidney. What's nice about this view is that you can also see the lung. So you can check for lung sliding and for the presence of a hemothorax. And you might also be able to see a mirror artifact or the spine sign in this view to check for a hemothorax as well. So this view that we are seeing here on the screen at the moment is not a sufficient view because we're not able to visualize the tip of the liver and the superior pole of the kidney. So it's only a partial view. Okay, so the next slide is a better view of a right upper quadrant. So you can see that this view with sweeping of the transducer, you can actually see above the diaphragm into Morrison's pouch, and you can see the space between the liver and the kidney and visualize the full pericolic gutter nicely in this view. Okay, then in terms of the next view, so the subxiphoid view, so with this, you are going to basically get a 4-chamber view of the heart. So you're going to place the transducer in the subxiphoid region and position the transducer indicator towards the patient's right side. So you're going to identify the liver, the cardiac silhouette with the right atrium, right ventricle, and left atrium, and the pericardial space. So you're going to look for free fluid in the pericardial space. And yeah, what Tammy always says with this is that you've got to be like a little submarine and you've got to try to sink below the sternum to get a nice view of your cardiac windows. Oh. Okay, so with this you can see that the probe is positioned nicely in the subxiphoid view. You can see the good contractility of all all chambers of the heart. You can visualize the right ventricle, the left ventricle, the right atrium, and the left atrium with the outflow tracts. And you can visualize that there's no free fluid around the pericardium, which would indicate an effusion. Okay, the next view is the left upper quadrant view. So with this, you're going to place the probe on the patient's left flank in the posterior axillary line in the 10th and 12th rib spaces. The transducer indicator is aimed towards the patient's head. So the point of this view is to identify the spleen, the kidney, and the diaphragm. And you're going to look for free fluid above the diaphragm, between the diaphragm and the spleen, and between the spleen and the kidney, and in the pericolic gutter around the inferior pole of the kidney. So with this, if you see a lot of gas and there's too much bowel in the way, then it means that the transducer placement is too anterior or inferior. So with this, often Tammy always says that you should try and do it like you're drinking a cup of tea, like you're an English person with your little pinky out, and your pinky should be resting on the bedside of the patient so that you can try get as good a view as possible with stabilization of your probe. Okay, so with this, you're going to slide the probe towards the patient's head in the posterior axillary line. You're going to fan the probe to scan the different regions, assessing for hypoechoic fluid in the subphrenic or splenorenal recesses. And yeah, so what's important is that it's usually much more common for fluid to occur in the right upper quadrant than the left. But if you do see fluid in this quadrant, then there's usually a substantial volume. Yeah, so with this view, once again, you need to actually visualize the tip of all of your organs. So this view is not an adequate view because you're unable to visualize the tip of this, the superior pole of the kidney appropriately. Okay, so the pelvic views. So what's important about this is that you need to have both views. So you need to have a sagittal and a transverse view in order to adequately assess the pelvis. So the sagittal view, the transducer is positioned just above the pubic symphysis. So you start in a sagittal plane and the transducer indicator is aimed towards the patient's head. You're going to identify the bladder and sweep through the pelvis from side to side and look for free fluid in the anterior, posterior spaces and lateral to the bladder. The transverse view, you rotate the transducer indicator to the patient's right. So you literally keep your probe in the same position and you just twist it. You sweep through the pelvis from superior to inferior and you look for free fluid all around the bladder again. What's really important with this view is that you turn down the gain in the pelvic views. Otherwise, it's too hyperechoic and too white. So you may miss free fluid if you don't sort your gain out. The reason this is also very important in our female patients in the ED is because, with trauma in ladies, often the free fluid will accumulate in the pouch of Douglas. Okay, so this is just showing the first view. So you're going to orientate the probe in a longitudinal plane with the marker towards the patient's head. And then you place the probe along the midline, immediately superior to the pubic symphysis. You're going to fan the probe to scan through the bladder, assessing for surrounding hypoechoic fluid. You're then going to rotate the probe 90 degrees, like you can see in the video. And that's now the transverse plane with the marker facing towards the patient's right. You're going to angle the probe downwards into the pelvis, fan through the pelvis, assessing all over for fluid in the pouch of Douglas, which is also known as the recto-uterine pouch in a lady, or the recto-vesicular pouch in men. A full bladder may cause what's called posterior enhancement, so therefore the gain may need to be lowered for proper visualization. Okay, then one of the most important parts of EFAST in trauma is assessing lung evaluation. So you're going to assess your thoracic sagittal views. So you're going to put the transducer on the upper chest of the patient in the second or third rib spaces in the mid-clavicular line, What's important is to do this on both sides of the chest. So just like you would assess breath sounds with the stethoscope on left and right, you need to do this with the probe. So you need to compare left with right. So you're basically going to place the transducer indicator towards the patient's head in the sagittal plane. You are going to identify the ribs and the rib shadows as key landmarks, and you're going to look for the pleural line just below the ribs. So the pleural line is an echogenic line formed by the visceral and the parietal pleura. So you're going to watch for lung sliding, which basically looks like little ants walking on a line. And you can also look for what's called a comet tail, which is a normal artifact that's usually present in patients. So that's a vertical line. Okay, so we can see on the video here the nice rib shadows, and in between the two rib shadows, you've got this beautiful sliding of pleura that looks like little ants. Okay, so some other cool techniques that you can do to assess your lung sliding is what's called M mode. So with M mode, you basically use it to accentuate lung sliding. And what's great is that you can save the still images. So medico-legally, if you've got an ultrasound machine that can print, it's great to have this in the patient's file to prove that they did have no lung sliding. So it's a great way to document an active way of seeing stuff. So basically you select the M mode from the scan modes on the keyboard, and you push the M mode key, and in normal cases the chest wall will remain stationary while the lung slides below the pleural line, leading to a seashore sign. So that's the top image. When a pneumothorax is present, no motion will be seen below the pleural line, leading to a stratosphere sign. Okay, so this is quite a nice video showing the normal mode. So this is where you can see the pleural sliding, and it stops. So what's important about this is you can see a lung point. So it goes from sliding to no sliding, and that's called a lung point, which is basically pathognomonic of a pneumothorax. And then at the bottom screen, you can see that you've got your barcode sign. So you've got your nice sandy beach appearance, and then it barcodes, and then you've got sandy beach and it barcodes. So this is a really nice way to have a static view of what you're seeing here with the lung point, and yeah, going from pleural sliding to no sliding. So yeah, it's just showing the barcode sign and then the seashore sign. In terms of the next steps with EFAST, so if you've got a trauma patient, this is just a nice summary. If it's an unstable patient, you can do a quick fast. If the fast is positive, then the patient probably needs a laparotomy and you should take them to theatre. If the fast is negative, then like I said earlier, it doesn't really mean anything. But if the patient is unstable, you need to still do a CT scan if you've got a high index of suspicion of an intra-abdominal injury. If a patient is stable, then you'll do an EFAST. If it's positive, then you can move on to doing a CT scan because the patient is super stable and can cope with that. If it's negative, then you do serial EFAST exams, a CT scan, or you can observe the patient and correlate clinically. But the most important thing to take home from this is that it's important to do repeat serial EFAST exams if there's a high index of suspicion of trauma or intra-abdominal free fluid. So also just an extra point is that you will only take to CT scan once your patient is stabilized. So at Barrow, they used to call the CT scanner the donuts of death, and it's because people used to send patients who were unstable to CT. So I think one of the other take-home messages is that only send to CT scan once your patient is stable. So I just wanted to use this as a reference. So this is a great guide that one of the guys from Helen Joseph actually suggested to me. They've got this in their ED. So it's a little handbook kind of pocket guide that's literally 4 pages long. And it's great because it's literally got all of your quick point of care ultrasound applications in it. So it's not just your EFAST, it's got a whole lot of stuff in it. So this is a nice summary. It literally is everything basically that you need to look for in an EFAST on one page. Cool, and those are my references. Does anybody have any questions or comments?
I wanted to say thank you very much, Tayla, for being brave and giving us this talk. It was really awesome. One point on your videos of the left and right upper quadrant, you mentioned both of them were indeterminate because we weren't able to visualize the one pole of the kidney. It's actually the inferior pole of the kidney that was absent from both of the views, not the superior pole. Yeah.
Okay, sorry.
No, that's okay. It's just it's a technicality.
Okay.
Can I ask you to go back to that slide with the algorithm of how to investigate patients?
This one?
Yes, but with the, so press your space bar or your slide again once stabilized. So that's a very important point, because if your unstable patient has got a negative EFAST, we need to find out why is the patient unstable, stabilize them first, and only then can we take them to the donut of death. Yeah. Cool. Any other questions, any other comments from anybody else?